Okay, we're going to take a look at urinary system and pathology here. We're going to talk a little bit about some of the procedures that are also involved, mostly because I think you're doing the exact same thing in positioning, so it never hurts, I think, to kind of reinforce the pathology versus procedures. First of all, with regards to the kidneys, now I just pulled this right off of, I think it was the Mayo Clinic website, kind of as a summary of what kidneys actually do. And you would do well to keep in mind that in a lot of cases what things do also affects it when things don't get done well. We know, for example, the kidneys remove waste products from the body. And for example, would be uric acid or urea, a certain amount of water, obviously, creatinine and things like that. The kidneys also serve to remove drugs from the body. Now, any drug that you take has a biological half-life. And what I'm referring to there is the ability of the body to eliminate it. So, as an example, contrast media. Contrast media really is a drug. If you inject somebody with about 100 cc's of contrast media and they've got normal kidneys, you would expect that 100% of the contrast media can be removed in about 24 hours, give or take a little bit. So that's one of the things that the kidneys actually do. And that's what I'm referring to when I'm talking about the biological life, or half-life. The other thing kidneys do is, through its ability to regulate fluid levels vis-a-vis urine, it balances your body's fluid. One of the things I talked about in the coronary is if somebody has congestive heart failure, then they have a backup of fluid into the lungs. If you give somebody a diuretic, which by definition should tell you something about what we're talking about here, you open up the floodgates, as it were, in the kidneys, and you increase urine production, mostly because of the water. As a consequence, you can dehydrate somebody that way. Well, the body has the capacity, or the kidneys specifically, have the capacity to do that day in and day out so that we don't develop congestive heart failure and that we don't get hopelessly dehydrated unless this is some kind of pathological issue involved. A couple of other things that they do is release hormones. Also is involved with keeping bones healthy with calcium, and part of this has to do with vitamin D, and to a lesser degree controls the actual production of red blood cells, which kind of makes sense again if you consider that one of the things that they're doing is regulating fluid, and also, where blood is concerned. Overall, kidneys will process somewhere in the order of about 200 quarts of blood on an annual basis, and out of that 200, you would think you would lose more fluid, but you actually don't. It's only a couple quarts, a half gallon, with the extra water and all. A lot of that reflects what you actually take in, and if you think about it, 2 quarts of anything is an awful lot, and that's one of the reasons why you think about it. They always recommend that you drink more fluid and all. The hormones that are involved kind of relate to what I was just talking about. Erythropoietin is a very, very important hormone that the kidneys secrete that helps stimulate the bones. Now it says bones, but really what it's referring to is the marrow, to increase the production of red blood cells. Think about this for a minute. You don't get enough blood going to the kidneys for whatever particular reason. One of the things the kidneys are going to respond is, because of its is to increase the situation where there is enough blood getting to the kidneys. Well, one of the ways you can do that is to have more messengers, and that's really what red blood cells are, because they carry oxygen. Kind of on the other side of that is blood pressure, because it also regulates that through its combination of angiotensin, renin, and aldosterone. Now the renin is specifically secreted by the kidneys, but in combination with the other two, that's kind of the grouping together that tends to increase or decrease your blood pressure. Now the other thing is that it also affects your forms of vitamin D, and really what it gets down to then is maintaining calcium in your bones. It may be interesting to note that when people have renal failure, it is not uncommon for them to develop osteoporosis and bone reabsorption, for example, in the AC joints, in the knees, and things like that. And the reason for this is that the kidneys are no longer involved with this whole maintaining calcium there, so it gets reabsorbed. So the kidneys are also very, very important for this. Patients who have end-stage renal disease, end-stage renal disease, ESRD, are at risk for bone fractures on top of everything else. If you look at the kidney itself, they're kind of bean-shaped. They're not huge. They consist of an outer layer, kind of almost like a layer, a protective layer, that is called a fascia. Now, a fascia is just a connective tissue. In a sense, it's a little bit like the pericardium. This one is going to directly adhere to the kidneys, though. And interestingly enough, if you have bleeding inside the kidney, you can actually push the fascia away. And, sometimes you can actually see the collection of blood because of that. Within the kidney proper, we look at them as having poles. So, for example, the upper portion of the poles is the upper pole as opposed to the lower pole. The central portion here on the medial side is called the renal hilum. And the renal hilum is like any hilum, an opening in the organ. In this case, the renal artery goes in, but also the renal vein comes out, as does the renal pelvis. Now, the renal pelvis is the, I guess you'd say, kind of centering gathering point for the calyces. So, looking on the inside, the initial portions that you see out here in the periphery is called the renal cortex. Now, the cortex is where the nephrons are predominant. Now, remember nephrons. Nephrons, of course, are the functional units of the kidneys, where you have this production of urine and things like that. So all of that stuff is going to happen out here first. The collecting tubules and all are more centrally located in areas here that are called pyramids. You may also see them called a renal medulla. These pyramids and all these collecting tubules are going to bring the waste products here into the calyces. Now, you have major calyces and minor calyces. You throw a couple of these together, you get a major calyx. Kind of cup-shaped looking structures. They're going to bring the waste, urine, and collect it on here into the renal pelvis, which has exited out through the hilum and has entered in, or the urine has, into the ureter. Now, ureters are these kind of muscular tubes that will bring urine down to the bladder. And at the bladder, they're going to enter into the posterior aspects of the, these ureters are going to enter into the posterior aspects of the bladder. So overall, you've got, in terms of the urinary system, you are looking at, for all intents and purposes, the kidneys, which produces urine, ureters, which are there for transporting urine down to the urinary bladder. And a urinary bladder does what bladders do everywhere, which is it really serves only for storage. And temporary storage is that for urine, because they are muscular and they will expel the urine out through the urethra. Now, when we do any kind of imaging for the urinary system in general, we're going to do a scout film of some sort. And I mean, it doesn't really much matter whether you're talking about a plain KUB, if you're doing a retrograde pyelogram in surgery, if you are doing a CT scan or any of these things, you want to do a plain image. The biggest reason for the plain image is to see if there is anything going on that could potentially be obscured by contrast media. Because if there's one thing we do is we use contrast media where the urinary system is concerned. If you look at this image right here, you probably at this stage can pick out the kidneys themselves. So, for example, on the left one here, there's the upper pole. You could kind of follow it down here neatly to the lower pole. And this area in here would be the renal hilum. Same thing on this side. There's the lower pole to the upper pole, and the hilum is in this region. But let's face it, they don't always look this good, or even close to being this good. So part of what you want to do here when you take a plain x-ray is to discern if there's anything else going on. How about if there were kidney stones? Okay. How about if one kidney wasn't even there, or was very, very small, or very, very big? There's a lot of different things going on. So when you take a preliminary x-ray or a scout film, if you'd like, most of the time you're trying to figure out if there's anything there that could be hidden, or if there's anything that's clearly visible, regardless of whether you put contrast media in there or not. And kidney stones are going to be a big part of that. Now, I mentioned the fact that nephrons are located for the most part in the cortical area and are the really kind of first step in terms of filtering blood. This is happening through the arterioles that enter into, as you can kind of see here, that whole, Bowman's capsule. And the glomerulus is just a capillary bed. Now, it's a little bit more complicated than this, obviously, but what essentially happens is a boatload of fluid, water, and the waste products are emptied out through the glomerulus. And what happens long term is a lot of it is returned back to the system through what is called the loop of Henle. So there's a huge vascular system here that was really not represented on this image. When water, for example, is pulled out at this point, it's how the kidneys are regulating how much water should be in the system versus how much water should be excreted, for example. Salt is also another one. The body attempts to conserve sodium, or chloride, or potassium. They will pull it out at this point so that they keep it at a normal homeostatic balance. When we do contrast media studies with kidneys, this is typically done intravenous, usually through an antecubital vessel, but not always. Okay, now an antecubital vein is going to be located, as you can see here, at the elbow. So we're typically going to start there. Now, it is possible to use PICC lines. It is possible to use other indwelling catheters. But really, for the most part, if you're talking about somebody, for example, who's an outpatient, this is probably where they're going to start. In a lot of cases, we're using upwards of 100 cc's. It may be a little bit less, it may be a little bit more, but in that general area of contrast media. This contrast media is going to flow through the vascular system. Now think about this for a minute. You've injected it into a renal vein. The veins are going to take it. By definition, a vein is a vessel that takes blood to the heart. So the contrast media here is going to be heading towards the heart. And it's going to go through, for example, our axial vein and the subclavian veins and the brachiocephalic veins into the superior vena cava, into the right side of the heart, to the left side, to the lungs, to the left side of the heart. We haven't got anywhere near the kidneys yet, guys. From the left side of the heart, it's going to go up into the aorta, goes down through the thoracic to the abdominal aorta, and into the renal arteries. Now, believe it or not, it takes about 25 seconds for all of that to happen. It happens really fast, which I should think would give you an appreciation of how quickly blood actually moves. Once it gets into the kidneys are going to do its thing, which is to eliminate it. And this all begins in the renal cortex, which is the site of the nephrons. And you look in the graph right here, this is an axial CT that's fairly early in the injection. Notice that there's greater enhancement on the periphery. This is the cortex. And you have less enhancement here in the central portions, which would be the medulla or the pyramids. And you see the same thing on both sides. So you've got greater enhancement on the outside, you've got less enhancement on the inside. And again, cortex versus medulla. Over time, the contrast media is going to be excreted out through the nephron into the collecting tubules. It's going to work its way to the medulla. So you're going to get more of a homogeneous looking kidney picture. Eventually, all of those collecting tubules are going to bring contrast media to the calyces. Now this is a volume rendered CT scan again, and this is done during the calyces phase, which is about 5 minutes in, or what we would call the pyelogram phase. So all of these things that you're seeing here that's looking really bright are renal calyx. Remember now, they're gathering up contrast media, this is a CT after all, from the collecting tubules in the medulla. So you have the renal pelvis, and then you have, of course, the ureter. This kidney over here is rotated just a little bit. I mean, this is not perfectly straight, but what you're actually looking at literally back in here is the posterior border of the kidney. This is the medial border, and as you can see, because it's rotated a little bit, we've got calyces and all, but you see how they're quite different from one another. But for example, if there was a mass back in here, it would push on the kidneys. This would give you an opportunity to evaluate that. Kind of a weak image. A A nephrotomogram. Now, first of all, you guys will probably never do a tomogram, but the idea behind a tomogram is to produce a slice of anatomy. When we talk about computed tomography, we're trying to produce a slice. Nephrotomography is a much more mechanical imaging that is done with a X-ray tube that is moving. Because it's moving, it blurs things out. So, for example, on our image here, notice that we don't see any of the posterior ribs to speak of back in here. We also don't see any bowel gas or anything like that as well. What we are seeing is a shadow with contrast media of the kidneys, the upper poles, the hilar region, and the lower poles. You see the same thing on this side. By the way, the reason that the right one is usually inferior relative to the left, of course, has to do with the presence of the liver over here on the right side. So this is the liver. Whoop, where'd it go? This is the liver here. The spleen is over here. Okay, spleen on the left side, liver on the right side. Now, this is another axial CT. This is actually even earlier than the first one. Patients laying on their back, there's the vertebral body. Notice how posterior your kidneys are. Okay, in fact, they're almost in a sense behind your vertebra. You can see how we got enhancement on the edges. This is the renal cortex, and not in the central pyramid area. Ditto. We're also seeing, if we come up here, there is the abdominal aorta. The renal arteries are coming off. That's the two of them right there. That's going to head here towards the hilum. At such time as it's going to happen, and the kidneys do its filtering thing, we know that the filtrate, if we could use that term, is going to go down through the ureter. But I said it took 24 hours to clear out contrast. That means some of it escapes the first time through. So, for example, what you are looking at here is a renal vein filled with contrast media. In fact, it's heading over here to the inferior vena cava. So, at the same time that the kidney is going to extract some of the contrast media and expel it out by way of the calyces, the renal pelvis, the ureter, and the bladder, some of it is going to get by and continue circulating through the body. Now, of course, it's going to make one circulation, but eventually it's going to come back here to the kidney, and the kidney will eliminate some of it. Some of it will get by, and it'll go through the body, and eventually come back here to the kidney. And that's why it takes about 24 hours to get rid of the whole 100 cc's of contrast media. This image right here is a KUV that is taken with contrast media, and it's sitting at about maybe 10 tops minutes post-injection into an antecubital vein. Might even be less, maybe it's 5 minutes. At this stage, now the liver is up in here, the right kidney is lower, there's a lower pole, and we see enhancement of all the calyces. Don't see as much enhancement here of the kidney tissue itself, mostly because it's now concentrated in here, in the calyces and the pelvis, and of course down here into the ureter. And the ureter is going to empty into the back of the bladder, which will gradually fill up. The left kidney is going to be higher. You can see a little bit of where the upper pole is and the border, the shadow, and the lower pole. One of the things that physicians do is they compare the symmetry of the kidneys. Are they both the same size? Well, we obviously know they're not going to be in the same place, but are they both about the same size? Is one too big? Is one too small? They're also going to be looking at the symmetry of function. Do they both enhance at about the exact same rate? Do they both empty at about the same rate? Okay. We look at the ureters. Do the ureters look intact all the ways from the renal pelvis down here to the bladder? And pretty clear, we've got a pretty good indication that that's the case here. Now, with regards to issues with the kidneys, in the fetus there are these kind of perinephric type of tubules that essentially are precursors to the kidneys. There's 4 of them. There's one on the 2 on the left side, 2 on the right side. As fetuses develop, these precursors fuse together and ascend up so that they will be positioned at about the level of L2, thereabouts, when the baby is born. So they have fused together and they've migrated superiorly. When congenital anomalies are concerned, it usually has something to do with this whole issue of fusing or migrating. Okay? Sometimes they don't fuse properly, sometimes they don't migrate properly. You see, these are the things that can actually happen. So if we take a look at a lot of congenital anomalies here, they relate to position, they relate really to this fusion issue here. Let's take a look. This is an example of another tomogram, and I wouldn't worry about that so terribly much, but you can see we're down here in the pelvis. Okay, here is the bladder, and it looks motiony because it is a tomogram. There's a ureter, here's the other ureter, and we see this evidences of enhancement here on both sides. What we have are ectopic kidneys. This is pretty unusual. The kidneys never ascended up into the retroperitoneum, into the abdomen. They are in the wrong place. The term for that is ectopic. I call your attention to a term you're probably more commonly familiar with, which is ectopic pregnancy. This means that a pregnancy has begun usually in one of the fallopian tubes and not embedded in the endometrium of the uterus. Now, something else that can occur for a number of reasons is that you can have a hypoplastic kidney. Now, hypoplastic means that it's underdeveloped and shrunken. And here's an example. You can see it's a comparison between the two of them. This is a reasonably normal kidney here. This one here, of course, is very, very small. It can happen congenitally, but I also want to point out that sometimes the kidneys just atrophy because of disease. And the biggest culprit of that, probably not so much anymore, but used to be, was chronic renal infections, especially in children. Okay, we used to have a big problem with that, much more so than we do now. They killed off the kidney so it never properly developed. Now, I should say that if that happens, one of the things that can happen is that you'll end up with the other kidney compensating by getting bigger. So, for example, here, this is a nephrogram showing just general enhancement with contrast media. There's the upper poles. You can see where the lower poles are. It's just a little bit of an early blush. We see virtually nothing over here. Okay, the kidney's not functioning worth the doggone, and is probably not even there to begin with. You've had overcompensation here because the kidneys still have to excrete urine. Here's an example of a hypoplastic kidney on a CT scan. Now there's your vertebral bodies again. Here's the normal one. Here's the other one. Okay, there is a huge difference here between the two of them. Obviously there is asymmetrical, if you'd like, development. Now over here on the ultrasound we're essentially kind of seeing the same thing. Here's the normal one. This is the skin, by the way, and here is the abnormal one. Now they're obviously not in the same place. What they do is they'll scan this way, and then they'll come over here and they'll scan this way. Now, some other things that can happen is when you have improper fusion of these, and one of the things here could be either a duplicated ureter or a double collecting system. So, for example, on the on the plain radiograph that you have here, we have one collection of calyces and a renal pelvis. We have a second collection of calyces and a renal pelvis. At some point, these two ureters, this is a duplicated urinary system, are going to merge together. You see there's only one here, but it has the appearances of having two different ureters. That would be reasonable. This one over here looks perfectly normal. Really what happened is during fetal development, this one fused properly or pretty close. This one didn't. Essentially, you almost had two different kidneys going here. You can see on the cadaver slice right here how we can have a duplicated ureter here that eventually merges into a single ureter. Now the picture there, unfortunately, with this color is not showing up particularly well. But here's another example where we have a double collecting system, two different ureters coming together that eventually fuse. And they're going to make their way down here towards the bladder and the pelvis. Now, a retrograde pyelogram is a surgical procedure where they will inject contrast media into the ureter directly. To do this requires them to introduce a cystoscope into the urethra, into the bladder, and they'll pass a little small catheter up into the ureter. Remember, they know where the ureters are. They're on the back wall of the bladder. they'll inject that little, they'll insert that little catheter in there, and then they'll inject contrast media, iodinated contrast media, into the ureter. So the contrast media is going to reflux or go in the retrograde fashion. Because remember, normal is going to be from kidneys, ureters into the bladder. What we've done here is we've injected into the ureter kind of backwards. So this is a retrograde. That kind of gives you an idea where that comes from. Pyelogram. The pyelogram stems from the fact that if you inject this long enough, you will enhance the renal pelvis and the calyces. You're never going to see the rest of that system though. Here's another one that is a kind of unusual situation where we have actual fusion of all of the kidneys together as one. This is called a horseshoe kidney because it kind of has the kind of cup shaped. You can see on the graphic right here that in this case the fusion is occurred down here in the lower poles of the kidneys. Now it may be that the kidneys are directly fused together, or there may be just kind of some kind of connective tissue that's holding them together. It can be either one. The problem though with horseshoe kidneys is literally what you're seeing here. The kidneys will be mal-rotated. Okay? Kidneys depend on position to properly get rid of urine. For example, us being upright uses gravity to cause the flow of urine out of the kidneys into the ureter. When the kidneys are rotated and they're mal-rotated, urine tends to begin to back up. If that happens, urine is a really, really good culture medium for infection. So now you're running into potential risks from that. So horseshoe kidneys in and of themselves are not particularly dangerous, but the fact that the kidneys are rotated or mal-rotated at the same time can be a problem. Now having said that, I want to point out kidneys can be mal-rotated for any number of reasons. It doesn't have to be just because of a horseshoe kidney. Now on this image right here, it's not a gorgeous image by any stretch of the imagination. Almost looks like we've got a double collecting system here. But I just want to call your attention to the fact that this is all dilated and relatively blunt. It's giving me a little bit of an idea that what we've got here is a case of hydronephrosis, or kind of blockage of the ureters up here into the renal pelvis, and everything's just backing up. If we look down in the lower urinary tract, of course we're talking about now the ureters, the bladder, and the urethra. There's not too many things that can happen from the congenital side, but certainly a ureterocele is a possibility. Now a seal is really an opening, okay, or a pocket in a sense. So a ureterocele is the ureter literally kind of bulging into the bladder itself. And that's kind of what you're seeing here. We've got a double collecting system going here. Surprised that there isn't an issue. And here's the bladder. It's filling up with contrast media. You'll see the basically the other side here too. And what's happening is it's bulging out like a bubble into the bladder. And in doing that, it's got contrast media within it, but it also has tissue which is displacing the contrast media while you see it. So you can see on the graphic right there, it's almost like it's bulging through. That's the ureterocele. Okay. Now, here's another one. This is a pretty wretched looking image here, as you can tell, but you can see there's this bulging structure going in here that's just really the ureter kind of just almost herniating into the bladder. Another thing that can happen would be kind of what I always called, you probably can tell why, mouse ears, and these are going to be bladder diverticulum. So in a sense, this is the opposite of a ureterocele. A ureterocele was the ureter bulging into the bladder. This is parts of the bladder actually bubbling or bulging outward, and that really makes sense because there's a tick. These things classically happen because of chronic bladder diseases, things that put stress on the bladder. Somebody who, for example, has a neurogenic bladder, neurogenic bladder means is that it doesn't contract normally and expel urine. So you might end up with these weaknesses here, these diverticulum within the bladder. Here's an example of this whole question of symmetry again. Now there is the vertebral body right there, and this is midline. If you look at the degree of enhancement here relative to here, you'll notice that the right side doesn't have quite as much enhancement and is just a little bit bigger or more swollen. This is evidence of edema within the kidneys and is a sign for somebody that has pyelonephritis. The way people get it, for the most part, is the whole urinary system. The urethra is relatively long with men, so bladder infections are uncommon with males. On the other hand, they're not much more than a few centimeters for women, so bladder infections are much more common. So bacteria actually can get into the bladder and colonize. That being the case, there is a direct conduit between kidneys and the bladder, which is the ureter. Bacteria-infected urine refluxes back up into the ureters. It is possible that bacteria can get into the kidneys and start up a case of a kidney infection. There are acute cases of pyelonephritis. They are usually present with high temperatures and severe back pain. It is also possible to have what is called chronic pyelonephritis. Usually we're not talking about things with high temperature and pain, but we're definitely talking about damaged kidneys. Here's another example of somebody with pyelonephritis, except in this case, this is happening because of some kind of bacteria that has produced gas. So our patient has emphysematous pyelonephritis. I'm assuming this is actually located within Gerota's fascia. Here's another one, the case with acute pyelonephritis. It's really showing up because of the distension of the calyces on these central portions. They are much more separated out than other images. If you don't believe me, go back and take a look at them. Again, this is evidence of edema in that kind of central medullary portion. It is possible, as I said, to have cystitis as well. Cystitis, remember, is going to be an inflammation of the bladder. One of the things that you typically see from something like that as a result is kind of over-exaggeration of the inside of the bladder. So I want to point something out. If this is the actual bladder wall, now remember, we don't see the bladder. All we're seeing here is the contrast media. Okay, you can kind of imagine that this is the roughened, expanded, swollen inside portions. And the reason that you're seeing these things like this is because it's being filled with contrast. The bladder cavity is being filled with contrast media, and it's kind of flowing in between all of these various areas. You can also see that our patient here, there is a ureter. I'm going to make, because they got an arrow here, that our patient here has reflux. Reflux means that the valve is permitting contrast media from here and other circumstances to be urine to go up in a retrograde manner, potentially all the way up to the kidneys. Reflux, as I've talked about before, is very, very damaging because reflux can lead to pyelonephritis, and enough cases of pyelonephritis will damage the kidneys, and you get enough damaged kidneys, then you end up with a dead kidney. And the kidney will atrophy, as you can see here, and you don't have any function. And if it's happening on both sides, you really got a problem. Okay, what's some things that can help contribute to this whole mess? Well, nephrolithiasis. Okay, let's break that down. Nephro, of course, is referring to the kidney. Lith means stones. Iasis means state of. So this is a state of having kidney stones. Another term for kidney stones is going to be renal calculus. Now, there are biliary calculus, which are gallstones. That's something different. The term calculus really then is referring to stones. With the kidneys, kind of like the bladder, kind of like the, we call it gallbladder, kidney stones can be either made of crystals that have kind of leached out from urine, or they can have calcification in them. Okay, as a consequence, as you can see here, most of them are going to be radiolucent. So on a plain KUB, you're not going to see a kidney stone. Doesn't mean it's not there, okay, but you're not going to see it. With some, they're going to be radiopaque, which means you'll actually pick them up on a plain radiograph. Okay, what we generally find if something is radiolucent is that we have to, with plain X-ray, we have to introduce contrast media in there to demonstrate the signs that there is an obstructing stone there. Right. Here's an example where somebody has kidney stones. So you can see there's actually a boatload of them here, just outside of where the renal pelvis is. Because it's blocked the ureter, there is no contrast media that's heading down the ureter, and everything is back flushed, or backing up here to the kidneys. Got a beautiful blush. The kidneys are working. Problem is they can't get rid of what it is they're trying to get rid of. On the other hand, over here, this is the normal functioning kidney, and we're at the point here where we got calyces and we got contrast media. So this is at least got to be 5 minutes in. One of the things, remember I told you, they look at is symmetry. Okay, there is not symmetry of function here. There is a stone. The other thing is the kidney is just simply bigger because it's swollen. Stones are concerned. On a plain radiograph, you will see them some of the time. You may see them in the kidneys like these are. You may see them in the ureter. You actually may see them down there at near the bladder. When there's a collection of stones in the kidneys, much as you see here, they're actually collecting into the calyces. We call that a staghorn kidney. Stags have those big horns, and they're kind of like this, just like the calyces. And that's essentially what you're seeing here. So this is an example of somebody with a staghorn kidney. Notice on the other side, not so much of an issue. Now, it's not to say that there can't be stones further down, but one of the things I want to call your attention is when you look at the pelvis, do not think that every calcific deposit that you see is a stone. A lot of them are calcified veins, or what we call phleboliths. Let's see if I can spell that here. P-H-L-E-B-O. That's the vein start. Lith. L-I-T-H. There's the stone part. So really, it's a, well, let's call it a stone, but it looks like a stone. But what it is a calcified vein. So a lot of times what you see down here in the bladder or in the pelvic area are actually going to be phleboliths and not the not kidney stones. On the axial CT here, this being anterior, you can see we're at the level there of the acetabulum, here and here, the femoral head, and there of course is the sacrum, so we're laying on our back. This is a bladder that is somewhat filled with urine. That's what we've got here. Urine usually has a Hounsfield value of about 10. And there is a calcific deposit right here, and it's located at the junction between the ureter and the bladder. So we would call that the uretovesicular, vesicle because of the bladder, junction, or UV junction. Okay, UV junction. And that's what they're referring to. When you have a kidney loosened and it comes down, it has to get past here because there's a valve here. And the valve is one way, but sometimes the kidney stone is too big, so it gets lodged here. And it gets lodged here, and then, of course, you can't get anything forward, so everything starts backing up. And that can lead to hydronephrosis. Now, even though there's a lot of different reasons why somebody can get hydronephrosis, the bottom line with it is we're talking about a dilation of the collecting system, the calyces and the renal pelvis. And this is going to happen because there's an obstruction in the ureter. It can happen because of kidney stones. It can happen because of tumors. God help us all, it can happen because of a pregnancy. Any of these things can do it. You can have hydronephrosis on one side. You can have hydronephrosis or bilateral hydronephrosis on both sides. Okay? When it happens on both sides, you reasonably can expect there's something going on in the lower urinary tract. If it's happening on one side, then it's either the kidney or it's going to be the ureter. So, for example, if you take a look at these two right here, things are fairly normal. They're the calyces. They look reasonably sharp. The renal pelvis. You're looking at ureters on both sides, extending down and going to enter into the back of the bladder. And the bladder, of course, looks like there's a prostate here, by the way. Yeah, will eventually open up into the urethra. Over here, on the other hand, we've got a decided asymmetry between both sides, with this one being grossly swollen, particularly the calyces and things like that, which is evidence of hydronephrosis. that really, especially since this one is normal, what that essentially is telling you is somewhere between here and here, there is a problem. Okay? Something is causing this. Now, it could be a kidney stone at that UV junction I was talking about. Okay? But it could be something else too. All right, here's an example of somebody with bilateral hydronephrosis. And what you can see here, you can see where the right is, there's obviously a discrepancy between the two of them. This one just flat doesn't look like it's working very well. This one is compensating in terms of size, but everything is all backed up. Remember, if it's bilateral, okay, logically it could be the ureters. That means then there has to be something wrong with both of them. That doesn't seem logical. What's more logical is that it's going to be something going on that stems from the bladder. For example, there could be reflux coming from the bladder, going on both ways. There could be because of chronic infection. There maybe perhaps could be some kind of tumor that's pushing on both of them. But usually speaking, it's going to be something at the lower urinary tract. Here's an example of an ultrasound showing you hydronephrosis. Okay, there's the area there of the perimeter of it, and you can see, I mean, you can tell they look like calyces. Here's the pelvis right here, and you can see how the calyces are grossly dilated. Now, you can have masses within the kidneys. Probably by far away the most common type of a mass, unless you count kidney stones, are going to be renal cysts. Okay, I have to admit, I think 1 out of every 3 adults in the United States have a renal cyst. Some of them have multiples. For the most part, they're not an issue. Sometimes they can bug you a little bit. All they are fluid-filled masses. They're just, not that big of a deal. Because they are fluid-filled, though, you really want to have something that, without the benefit of contrast media, can show you that difference between fluid versus kidney tissue. So they are best really evaluated by ultrasound and to a lesser degree CT. Ultrasound is really the one that's going to do it, because really, much like what you're seeing right here, fluid, when it's collected, is going to look like essentially almost a nothing. Notice we get all kinds of echoes down in here and stuff like that, but it's almost like there's nothing here. They vary in size. They can be quite big. They can be multiples. The biggest problem you have to worry about with multiples is the hereditary disease. It's called polycystic disease. This unfortunately can lead to renal failure. Now, this is not the common garden variety renal cyst. These cysts are really, really in bad shape. Okay, so for example, if you look here, it's a plain radiograph. There is this large mass that's apparent, somewhat dense. It's showing up as bright, displacing the bowel over here and things like that. And come to find out what they had, there was a cyst. This is not a tumor or anything like that. It's just a big fluid-filled bulgy thing. And you can kind of see how it just looks like a big bubble. Polycystic disease, though, is not just a big bubble. Polycystic disease means is that you have so many, you're overwhelming the kidneys. This also happens incidentally to the liver when we say this. So, for example, this is a kidney, unfortunately. There's the pelvis. Somewhere in here we've got kidney as well. This may be the liver. It's kind of tough to tell. But as you can imagine, these kidneys are not functioning very well because all they are is big pockets of fluid. Now, with regards to carcinoma, renal cell carcinoma, or RCC, is really the most common renal masses, renal malignancies out there. It is possible to have lymphoma in the kidneys and things like that, but if you're talking about strictly where the kidneys are concerned, you can anticipate either having a renal cell carcinoma or a transitional cell carcinoma. Now, renal carcinoma has another name. It's not used very often. It's hypernephroma. Don't mix that up with hydronephrosis. For the most part, the first sign that somebody will see indicating that they have renal cell carcinoma is going to be passing urine, passing bloody urine. A condition is called hematuria. And they will see the pink and all, and then go to the doctor, and unfortunately it turns out that you have something like this. Okay, so yeah, keep the two of them straight. Now, renal cell carcinoma then is of the renal tissue. So that's going to be the cortex and the medulla. Transitional cell carcinoma will be of the calyces, renal pelvis, ureters, down into the bladder. Transitional cells are specialized cells, the specialized epithelial cells. Remember, it's a carcinoma. Okay, that stretch. That's one of the big things. So when you develop a transitional cell carcinoma, you can usually anticipate it's going to be, like I said, those particular parts where you get kind of stretchy stuff. Renal cell carcinoma, we're looking at, for example, the nephrons. Now, a congenital tumor, also known as a nephroblastoma, is Wilms tumor, and this is not a particularly fast-growing tumor. So, for example, a child can be born with this present and never absolutely know that they have it. Over time, unfortunately, though, it does grow, and owing to its position, it's going to displace things. So it may be that the first thing that kind of gives an indication that a child has a Wilms tumor could be, for example, pain or bleeding or some kind of small bowel obstruction, something because it's pushing. In this particular case, you can see it's quite large. Now, Wilms tumors are, in a lot of cases, not only congenital, but they're also bilateral. And that, of course, makes for a very, very big challenge when you're trying to manage something like this. In addition, removing the kidneys for a child means that you're going to run into problems related to other things, including bone growth. The little kids that have been on television shows, Emerson, come to mind, all suffer from renal disease, end-stage renal disease, and it stunted their growth. And all of this happened early in their lives, and so they didn't grow properly. Because remember, one of the things we talked about is the kidneys are managing the whole vitamin D situation, which promotes calcific deposits, bone growth, in other words. Now, I mentioned transitional cell carcinoma. What you're looking at here are examples of transitional cell carcinoma in bladders. In this case, and then you can see here now, the bladder itself is filled up with contrast media from the urine. Okay, it's come through the ureters. And because there is a mass growing in here, as you can see here, it's bulging in and it displaces the contrast media. Here, it's much, much more dramatic. So let's say, for example, if this is really where the bladder is located, and the bladder muscles, and inside the bladder, on the other hand, is where you'd have, in this case, either contrast media or a large mass growing. And in fact, it looks like it's taken up half of the bladder itself. That's usually going to be a transitional cell carcinoma. Okay, some other diseases of the bladder. You can have calculi in the bladder. Now, most people think, well, they came from the kidneys. Well, it's not necessarily the case. Because as a general rule, a kidney stone is small enough that when you pee it out, okay, it's gone. These are going to be happening because of chronic retained urine. Where older men are concerned, this will happen because of the prostate. If you have what is called benign prostatic hyperplasia, this takes and enlarges the prostate such that, and the prostate surrounds the urethra, and it closes it up. So now you can no longer pass urine properly through the urethra. One of the things that happens as a result of that is that you end up with lots and lots of urine being retained, and you have calcific deposits. If it happens long enough, you will develop bad calculi. The other reason why something like this would happen is if you have somebody who has no bowel or bladder function. For example, somebody who has a spina bifida. If they don't have the ability to contract the bladder, they can't expel the urine. So kidneys are working just fine. Kidneys produce urine. Urine goes down into the bladder. You can't expel it. In other words, they don't get the feeling like they have to go to the bathroom. So the bladder gets bigger and bigger because it's retaining urine. Now, what these kids do, or adults, is that they have to catheterize themselves. So they self-catheterize, do this. And if they do it diligently, then there probably should not be a whole lot of problem. But the problem with diligence is that it's kind of difficult. If you're, for example, in a restaurant and you've had 3 glasses of iced tea, you can excuse yourself, step into the restroom, and you take care of the problem. Okay? These folks here are going to have to step into the restroom and then catheterize themselves. And as you can imagine, that's kind of logistically difficult and all. Now, but if they don't do that, then you have the problem with retained urine and the potential, again, for development of bladder calculi. One of the things that this tells you is, and this is really pretty important, don't clip the symphysis pubis anytime you're looking for something that relates to the urinary system. In fact, I would venture to say that you probably need to come down here even lower, because don't kid yourself if you don't think that a stone can't be lodged in the urethra. Okay, other things that can potentially happen. I'm more interested in this image that's over here to the left-hand side. Here's a patient that presents with a shattered pelvis. The femoral head has just rammed through the acetabulum. Okay, the way this is likely to happen is if somebody is sitting in a car and the car has a head-on collision and the knee of said person slams, for example, into the dashboard, and in doing so, and of course the whole body is going forward, well, the femur stays intact, but it rams through the acetabulum. And as you can see here, we got some rather nasty shards here. This is pretty dangerous. Well, one of the things that wouldn't surprise you is that this is a patient that's going to have a huge hematoma. In other words, there's going to be massive bleeding going on here. And what it'll do is it'll displace the bladder over. You can see how it's getting pushed and pushed and pushed. And this is happening because of all of the blood here. Now, this is just a little bit different. There's actually blood itself in the bladder, okay? Now, this could happen because of damage at the kidneys. Again, this could be trauma, but it also could be a tumor.